Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of Stand Medical Notes. So let us move forwards. And previous videos of previous 2-3 videos, I think we have discussed about the pathologies of lung parenchyma. So in this video, we will discuss about the pathology of the pleura. Okay. So let's begin with the name of Almighty. So pathology of pleura. So remember, pathology of pleura can be discussed in further subheadings. So number 1 is pleural effusion. Number 2 is pneumothorax. Number 3 is pleural plaques. So in these 3 things we will discuss in the pathology of pleura. Okay. Coming to the first one, pleural effusion. Pathophysiology, abnormal accumulation of fluid. It can be transudated, for example, due to raised venous pressure or hydrostatic pressure or decreased oncotic pressure, or it can be exudate due to infection, inflammation, blood, accumulation of blood, okay, or accumulation of pus. So accumulation of a transudate, exudate blood, also known as hemothorax, okay, and one more is pus. So pyothorax, you can say it as pyothorax or empyema. So these are the 4 types of pleural effusion we can see pathophysiologically. So let's see what are the findings under this pleural effusion. So number one and the first finding which we see is blunting of costophrenic angle. Second is meniscus sign, okay, and other thing is loculated pleural effusion. So blunting of costophrenic angle is the earliest sign of pleural effusion on an erect chest film. So it indicates a small effusion and it is a very minimal finding. Okay. Second is the meniscus sign. What is meniscus sign? Concave up line as fluid tracks up the chest wall. For example, if these are the lungs, okay, and you see something, if the left lung is involved, something like this in the left side or something like this in the right side. So this is nothing but fluid, okay, it accumulates like this. So this is known as the meniscus sign, okay. It tracks up the chest wall. Where it is moving to the what do you call, axilla, okay, apex of the axilla. So this is known as the meniscus sign. And blunting of costophrenic angle is nothing but when you see here like this. So normally this is very sharp angle, and right side here, these are sharp costophrenic angles. So when these are blunted, you see like this. So that means some fluid is accumulated, or like this here. So some fluid is accumulated here and here. So that is blunting of costophrenic angle, and this is the first sign which you see in pleural effusion. Okay. Sensitivity, what is the detection thresholds? So in lateral chest X-ray, the sensitivity is more than the posterior anterior chest X-ray. In lateral chest X-ray, at least 100 ml of fluid is required to see the blunting of, there you don't see costophrenic angle, but you see the blunting of costophrenic recess there in the lateral chest X-ray, okay. If this is the lateral chest X-ray, okay, so you see 2 recesses, no? So this blunting, these are known as the costophrenic recess, okay. This is the sternum, and this is the heart, and these are the vertebrae. If these are there, then this is known as the costophrenic recess. So at least 100 ml of fluid is required to see blunting of this costophrenic recess, okay. In lateral chest X-ray, if you want to see pleural fluid, 100 ml of, at least 100 ml of fluid should accumulate. And in PA chest X-ray, at least 300 ml of fluid is required to see pleural effusion. And ultrasound is the most sensitive investigation modality where you can see small effusions of 50 ml also, okay. You can see 50 ml effusions also in ultrasound. So just to revise, in lateral chest X-ray, at least 100 ml is required. In PA chest X-ray, you require at least 300 ml, and in ultrasound you can detect even 50 ml of pleural effusion fluid, okay. So ultrasound is preferred for small effusions. So what is loculated effusion? Fluid trapped by adhesions, often within a fissure. Fluid trapped by effusion. So it is a transudate only. So that is trapped by adhesions, or it can be exudate also, or it can be resolving empyema also. So which is resolving by fibrosis. So because of trapping in the adhesions, there is loculations. So that trapping, no, if I explain you by example by drawing here, I will just drop this. Okay. So if this is the okay the thing which you see, and this is right side, this is the heart. Okay, here you see the horizontal fissure in the PA chest X-ray. Okay, and in the lateral chest X-ray you will have like this. Okay, this is the sternum and these are the vertebrae. Here you see the oblique fissure like this. So when you see the effusion collected in the fissures, so you will notice a collection like this in the horizontal fissure in the PA chest X-ray like this. This is filled like this. Okay, and in lateral chest X-ray, if the oblique, if the effusion is what do you call trapped inside the oblique fissure, then you can see something this type of accumulation in the lateral chest X-ray. Okay, so this kind of, so this is trapping, this is loculation inside the fissure, but you can see this one here also loculation toward the side D shape in PA chest X-ray. So here you don't see anything, but here you will see some trapping of fluid, D-shaped trapping. So you see this kind of D-shaped opacities, loculations in empyema or resolving empyema in the form of fibrothorax like thing. You can see this type of loculations, or you can see here also any side, any it can be the loculation, you can see any side. Okay, so that's about the explanation of these things. Okay, now we will move towards the X-rays now. So see here, just to note, PA and AP erect chest X-rays are insensitive to small pleural effusions. Less than 100 ml, at least 100 ml is required for lateral. So pleural effusions less than 300 ml can be undetectable on an erect chest X-ray. Lateral chest X-rays detect effusions earlier than the PA and AP erect projections. Effusions of more than 100 ml are detectable on the lateral chest X-ray. They are seen in the posterior costophrenic recess actually. Supine chest X-rays may miss large amounts of pleural effusion as the fluid collects posteriorly, thus resulting in hardly visible density changes. So you will have some sign when you take a patient who is having effusion, who is lying down, whose X-ray is taken in lying down position. That is known as, I think, some recess sign. Something is there. We will learn that in the coming slides. Okay. So ultrasound can detect very small effusions. 50 ml also it can detect. So chest X-rays and ultrasound both cannot distinguish between transudate, exudate, pus, blood, or chylous contents based on their radiological aspect alone. But they can ultrasound can give clue, and even chest X-rays, if you see some loculations, if just I have explained, so you can get a clue, but they can't distinguish between transudate, exudate, hemothorax, empyema, and chylothorax. All these things they by themselves they can't differentiate these things. Okay, so that thing we should that thing should be kept in mind. Okay, so ultrasound is more sensitive than chest X-ray in detecting effusion, and ultrasound is more sensitive than chest X-ray in giving clue whether it is a transudate and exudate or pneumothorax or pneumothorax, whether there are loculations, whether there are septas which are present in the pleural cavity. So ultrasound is more sensitive than chest X-ray in all of these X-rays. So whenever you do a chest X-ray for pleural cavity collection, no, you just send for chest ultrasound also. That is very helpful, and that is very much helpful. Okay, that is inevitable. When you found a effusion, when you find a effusion in chest X-ray, you should send the patient for transthoracic sonography to see for that any loculations or any signs which are giving clue towards exudate like thing. Okay, now we'll move forwards. See, now these are the X-rays. Okay, radiological features of pleural effusions include blunting of the costophrenic angles, meniscus signs in large effusions, fluid accumulation in the lung fissures, and mediastinal shift away from the effusion in very large effusions. So these are the signs. Number one sign you have, one is blunting. Number two is meniscus in large effusions. Number three is fluid accumulation in fissures, and number four is shift of the mediastinum away from the effusion in case of large effusions. Okay, so these things you will see. Now we will see these things. So you can see this chest X-ray now, both APA and lateral. So you are seeing blunting of this left side costophrenic angle, and the okay, here you are seeing blunting of the left costophrenic angle. Other things, okay, so under overexposed chest X-ray, there is no rotation, and well inspiration is also good in this chest X-ray. Okay, and you see this, nothing is there. Okay, so just you are seeing here blunting of costophrenic. So there is effusion in the left side of the chest X-ray. Now same thing you see here, you are seeing, oh, see this is more sensitive, an effusion starting from here up to here. This is meniscus sign in a lateral chest X-ray, and this is also a meniscus sign. You can say this is a meniscus sign. Okay, this is called as meniscus sign. See, this all is the collection of fluid. So this is actually more than 300 ml, because in PA chest X-ray, if you want to see effusion, the fluid should be more than 300 ml. Okay, so it is more than 300 ml. That's why you are able to see here. Okay, now this chest X-ray, but and all you can see here. Yes, in this chest X-ray you can see this fissure. No, so first we will solve systematically. So it is, exposure is good, there is no rotation, and inspiration is also good, but you can see here. Okay, now you separate into zones. Okay, compare the zones, you see the hyla. Okay, and other things you can see is what you can see other things. This thing is the important. This is the horizontal fissure which is prominent because of collection of fluid in the horizontal fissure. Okay, that thing is there. Along with that, you can see some wiring like things, metal wiring things you can see, and here you can see a circular thing. See, so this is the peripheral side. Whenever you read chest X-ray, you just read like this. You are examining the periphery, and then you are examining the center. This is easiest thing which you can do. So here you can see wires. See wires, you can see, see wires, and here also you can see a circle like thing. So what is this? So this is a patient who underwent open heart surgery for valve replacement. So this is an artificial valve, and these are the sutures of the sternum which are put on. Okay, and you can see there is some widening of mediastinum like thing. You can also see widening of the mediastinum. Okay, these all things and here the most important. So you are seeing this one, and again you are seeing the blunting of the right costophrenic angle here. Okay, and now in the lateral chest X-ray, see again you are seeing the blunting of the costophrenic recess. Same thing, valve in the heart you can see in the lateral chest X-ray also. And see here, this is the horizontal fissure. This is the horizontal fissure which you can see prominent. This point, this is this one, sorry. Okay, now we will see what things we have learned. We will see now. So pleural effusion with meniscus sign, pink lines on the left, blunting of the posterior right costophrenic angle and fluid in the horizontal fissure and in the right oblique fissure, mitral valve replacement, circlage wires after median stenotomy. Note that the patient has multiple osteoplastic metastasis, light pink asterisk osteophytes. So this is about actually this second image. Sorry, see here. So we have missed these things. Many things we have missed. So wires we have identified. Okay, We have identified the wires. This circle is this wall replacement we have seen, and this fissure also we have seen, and this one is we have seen. So we have identified these things. Okay, this is the oblique fissure, and this is the lateral fissure. Lateral fissure is uh, thickened. So we have identified this, but this asterisk, no, these are osteophytes, metastasis to the osteophytes, and these things also, these are the metastasis. So that is the thing which he is explaining about. So same thing he is saying here. Pleural effusion with meniscus sign. So we have seen meniscus sign on the left. Blunting of the posterior right costopharyngeal, we have seen that. And fluid in the horizontal fissure, we have seen that. And the right oblique fissure also. Okay. Mitral disruption, we have seen. Circlage wires, we have seen. Patient has multiple osteoblastic metastasis. So we have missed this thing, because they are not so prominent, no. These things we have missed. These things we have missed. These things, nothing is prominent. Okay. Okay. So the gross things we have seen. Now we will see this one, the first one. So we have yes, massive pleural effusion with meniscus sign. So this is the pleural effusion. Yellow in the lateral and light pink in the posterior green arrow, and anterior costophrenic angles as well as in the cardiophrenic angle. So this is the meniscus sign. Okay. So that's about the chest X-rays. Okay. Now we'll see some other images of this pleural effusion. Now just see this one. Why I have put this images is, this is more than the previous image. This is actually moderate effusion, you can say. Moderate effusion, and this picture is actually full whitish. So it is underexposed picture. Okay. And you can see this part of the lung, the distance between the ribs is increased. That means this part of the lung is hyperinflated, and also this part of the lung, you can see it is hyperinflated. Okay. So this is a image or X-ray of moderate pleural effusion, and I think this is compensatory hyperinflation with increased lucency. Okay. Okay. Any other thing which we can see in this image? Nothing. Okay, you just see this chest X-ray now. So this chest X-ray shows a large effusion. That was moderate. This is a large effusion, and this is a large effusion. This is fundus, gas in the fundus region of the stomach. Okay. So this is a chest X-ray of large pleural effusion with compensatory hyperinflation of the another lung and the upper part of this lung. There is compensatory hyperinflation of these lungs. This is a, so meniscus sign you are seeing this. Okay. This is well exposed, no rotation. Okay. And increased lucency you are seeing. So hyperinflation is there, compensatory. So you see this thing now. But you are not seeing any mediastinal deviation here. Okay. Trachea is in the center. Even though the effusion is long, the trachea is in the center. It is not deviated towards the left lung. Okay. See this one. Oh, this is, what do you call, whole left lung is filled with pleural fluid. This is enormous amount of pleural effusion. Okay. Whole, and you can see compensatory hyperinflation of the opposite lung here. So this is enormous, massive pleural effusion. Okay. But still you are not, I think, okay, there is some deviation of trachea towards the right side here. Okay. Yes, there is a deviation of trachea to the right side here. Okay. There is deviation of trachea towards the right side. So this is massive pleural effusion, X-ray of massive pleural effusion. Now we'll see some other X-rays. So X-rays of loculated pleural effusion. So what is loculated pleural effusion? It is trapped pleural fluid, does not layer out in dependent position. This is important. Okay. This can mimic pleural masses. Causes of pleural fluid loculation include pleural scarring, thick fluid with pus, nothing but empyema, or lung distortion following surgery. Okay. So these are the causes. So yes, you can see here, this is looking like a mass. So this part of the lung is hyperinflated, increased lucency. You can see, you are able to see distance between the ribs is increased and it is more blackish in color. And you can see mass like thing, this one. Okay. And this is memory shadow actually. Memory shadow. This is the gas under the fundus of the stomach. Okay. And here this is okay. You are able to see, and this is memory shadow. Okay. The angles are sharp, but the angles are sharp. So there is no blunting of costophrenic angle and no meniscus sign, but there is compensatory hyperinflation here and here. And you can see a mass like thing, but if you take a lateral chest X-ray, this is oblique fissure, and this is a collection in the oblique fissure, and this is in the posterior mediastinum and also in middle mediastinum compartment. So you need to differentiate this depending upon the signs and symptoms of patient, and further differentiation you can make based on CT scan, because it is difficult to make whether it is a mass or it is a loculated pleural effusion. This is collection in the oblique fissure. So it is encroaching on the vertebrae. That's why I'm saying it is in the posterior compartment of mediastinum. Okay, so let's see. See here, I said no. So this is loculated collection, and this asterisk, what is this asterisk? We will see. So loculated fluid accumulation in the right oblique fissure in a patient with left mastectomy. That's why you're not seeing any breast shadow here. Okay. Green asterisk, this one. So this is left mastectomy. And lymphangitis carcinoma. That means the patient had breast carcinoma of the left side. So that's why, and that is removed. That's why you are not seeing any left memory shadow, but you are able to make out this part of the lung is consolidated. It looks like there is something in this part. So there is effusion, I think. Okay, this is effusion only. Okay, in this picture you make out effusion like this, and this is a collection in the oblique fissure. Okay, but here you are not able to see any such kind of thing here. So I think this is not any collection. This is memory. Here you can make out no memory shadow. It is a memory shadow actually. Okay, that is loculated pleural effusion. Other pictures, so you can see in these pictures also. Okay, here this is the horizontal fissure. You can see collection in this horizontal fissure, and blunting of costophrenic angle is also there here, and there is cardiomegaly also there. See, there is cardiomegaly, and this is the carina left side and carina right. This is left side and this is right side. You see some loculated collection in the horizontal fissure also, and other than the horizontal fissure also you can see this type. This is the horizontal fissure, and here, and there is blunting also. So loculated, and see here the costophrenic recess is blunted. This is the oblique fissure, this is the horizontal fissure. Okay, and this is the loculated collection. Okay, now we will see what is the majra. Cardiomegaly is also there. Cardiomegaly is also there. Okay. So typical aspect of loculated pleural fluid accumulations or chest X-rays includes an elongated opacity along the direction of the fissures and with tapering ends. So that's why I said no. This is very important point. Typical aspect of loculated pleural fluid accumulates on chest X-ray include elongated opacity along the direction of the fissures with tapering ends. CT is usually not needed to make the diagnosis unless the opacities fail to resolve after congestive cardiac failure treatment. That means these loculated effusions which you are seeing in the fissures, these are due to cardiogenic pulmonary edema. Cardiogenic pulmonary edema. So you are able to see cardiomegaly also. That is a clue that it is due to it is due to cardiogenic pulmonary edema. So these are corresponding CT scans. So this is horizontal fissure, oblique fissure. This is the oblique fissure you can see. Okay, we are not concentrating more on chest X-ray, CT scan. We are concentrating on chest X-ray. So just to summarize here, so this is blunting of the costophrenic angle and meniscus sign you can see here, and here Also you can see blunting of the right costophrenic angle and horizontal fissure you are able to make out here. Okay, and mitral valve and sutures of the sternotomy, and we missed the this metastasis to the vertebrae here. And this is moderate effusion, this is large effusion, this is massive effusion, okay, which is causing tracheal deviation, and there is compensatory hyperinflation of the other parts of the lungs also. So this is oblique fissure, you are able to make out oblique fissure accumulation in loculated effusion in the oblique fissure with, this is the left mastectomy, the left breast is removed because of carcinoma. So this is cardiomegaly, and there is accumulation in the horizontal and oblique fissure both, okay, and because there is cardiomegaly, likely it is cardiogenic pulmonary edema. Okay, that's about pleural effusion, all about pleural effusion. Okay, I think this is enough for today. We will meet in the next video. Thank you.